I think that's a.
We do now. All right, I turned on the recording so everybody knows we record these meetings. So if someone misses them, they can watch the meetings later on. I'm Gene Ransom, CEO of MedChi. You guys all know that though, and I really appreciate the participation from everybody. Somebody needs to mute themselves. That would be helpful. Whoever's got the news on in the background. All right, well, we'll figure that out and go from there. Anyway, so to start this morning, I just wanted to. Good morning, Nicole is here. So it looks like the ED just came on yellow alert. Oh. It looks like there's. Can someone figure out who that is for me? There's one patient that has about a 6-hour wait, longest wait. Oh, that is not good. The rest are about. There we go. Sorry, I figured it out. Sorry, it's difficult to kick the meeting off and figure out who I need to mute. Anyway, back to where we were at the very beginning. I'm Gene Ransom, I'm the CEO of MedChi, but you guys know that. We've been doing these EQIP meetings the third Friday of the month for quite some time now. This is an exciting one though, because we are actually in open enrollment, as you all know. July 9th marked the beginning of access to the portal, and we think we've had a little over 20 groups who've accessed the portal, so that's great news. Today, we've got a couple exciting things we're doing. The HSCRC staff is going to go through some of the opportunities around EQIP, and we're going to talk about some of the issues. And obviously, we're going to be available to answer questions as people sign up. I did want to make a couple points with regards to sign up to think about, because some of the people on this call, I suspect, are thinking about doing this, but maybe haven't gone into the portal yet. I would just strongly encourage you to at least go in there and look around and see what's going on. I would also strongly encourage you, if you're thinking about doing this, regardless of whether you're planning on doing it or not, then number one, check and make sure your PCOS is up to date and correct. And number two, make sure you're signed up for CRISP. I would also ask, maybe as a third thing, that if you're aware of other practices that you think could benefit from it, please make them aware of it. You know, we have over 30 days to sign up for this thing. We've got close to 45 days to sign up for this thing. So if someone knows nothing about it now, we can certainly get them educated and get them involved. So we want to make sure that we make practices aware of the opportunity. So please share the information. Maddie and I are both very happy to do phone calls on a one-on-one basis with any group. And the HSCRC staff has been excellent about doing those and helping with opportunity evaluations. If you aren't sure if you're prepared or signed up for CRISP, you can either contact Chris directly or you can contact MedChi. Particularly if you're in an ambulatory practice, we do the signups for ambulatory practices at MedChi for CRISP. But just make sure that, and maybe this is more to some of the smaller practices that we're aware of, we're ready to help and willing to help. We don't want to see somebody who wants to participate in the program tossed out on a technicality. So having said those things, I did also want to thank the HSCRC staff who has worked quite a bit over the last few months to kind of get this thing up and running and to help practices and do the meetings. I usually do it at the end of the meeting, but I wanted to do it at the beginning so everybody heard it. And I will go ahead and turn it over to Maddie Jackson, who's going to be presenting or starting the presentation today for the HSCRC. Go ahead, Maddie.
Great, thanks, Gene. Okay, so today we have a couple of areas that we want to talk through with this subgroup. The first is we have a couple of administrative enrollment updates to Gene's point about our enrollment being open. The second is that we'll roll out our final quality methodology for that CQS adjustment on the incentive payment. And then finally, we'll walk through some statewide numbers on opportunity analysis and how we're kind of thinking through performance analytics and getting that information back out to you all through CRISP through the performance year. So for some administrative and enrollment updates, the EQIP entity portal in CRISP is now open for enrollment. We'll probably say this like 8 more times in the meeting just to drive it home. But we do want to note that everyone that wants to participate in your EQIP entity or any EQIP entities that want to be formed must be formed prior to September 1st. This is the deadline for which we have to submit all NPIs back to CMS for vetting. And additionally, there won't be another participation opportunity again until performance year 2. So this is really the shot to get in for performance year 1 starting January of next year. I also want to note that we will start contracting after we get people into the EQIP entity portal. So after our CMMI vetting results are done, we know who is actually qualified to be in the program by CMS. We will start contracting in early October. So we don't expect for all operations to be finalized by the September 1 deadline. We just need to have the listing of the NPIs that you would like to include in your EQIP entities. Additionally, I want to note, because this has come up a little bit, is that care partners who are not practicing in 2019 or were not a part of your EQIP entity in 2019 may still be included in your Performance Year 1 care partner rosters. We only need to assess if your EQIP entity is eligible, meeting eligibility thresholds in the aggregate based off of your 2019 baseline. So if you have new providers that have come onto your practice or providers who have just started practicing, they are still eligible for performance year. What we'll simply do is we won't have their experience included in your baseline and your target pricing. They just will be subject to those targets at the EQIP entity level. Additionally, we wanted to note that a lead care partner or a lead physician NPI is required to initiate enrollment. After this initiation of enrollment into CRISP, you can elect administrative proxies right after the second step and just turn it over for performance management should you elect to do that within the system. This step is really critical in terms of our CMS kind of engagement and ensuring that we have fidelity to that process. We need to know that an actual participant in the program has initiated this enrollment and this process. Otherwise, we don't have any sort of kind of check on that there. So our CRISP team is on standby to ensure that you guys have all the support you need in getting those care partners signed, credentialed into CRS and CRISP. So go ahead and reach out to them now if you have an idea of who this lead care partner physician is. This is really the only responsibility that that person will be required to take on additional to participation in the program. And then we also wanted to note what this baseline data that you will be seeing in CRISP is provided for. This will help you determine your eligibility and then your participation opportunity. We want to note that this is not your official target price. That will be available January 1st of 2022 for you all to compare to. And then also that your tiered shared savings ranking will be based off of the episode elections. So if you change the episode categories in which you elect within the portal, your tiered shared savings ranking will change with it as you go along. So you'll be able to see kind of the relative adjustment there. If you are interested in getting in as an EQIP entity, or you have lead care partners, or just general questions about the program, please reach out to our CRISP Health inbox at equip@crisphealth.org. They are very great for getting you up with access to EQIP, just answering any general questions you might have about the program, getting you to the right person to ask your questions if they're not the right person. So they're really the one-stop source for everyone should you have questions. Are there any questions on this enrollment kind of side? I know because we've been getting some trickling through, tried to hit most of them here, but I'm happy to take some now. Great. So a couple additional updates now available on our website. We have our EAP training and user guide available. So it's all step-by-step of how you log into CRISP, how you work through the CRISP system, and really utilize that tool that we've built out. Additionally, we posted our technical policy user guide. It is also a step-by-step of all of the policy adjustments and calculations that we are doing at the HSCRC level to really calculate your performance. So both of those are available there by that link at maryland.gov. So again, any resources that we're providing, we're putting up there. So please keep checking in because we're quickly adding things day by day. Additionally, I want to note that Prometheus episode codes, the triggers, relevant diagnosis, and relevant procedures are available upon request for EQIP entities who are initiated in EAP. So you have to be enrolled into CRISP and signed up and have an EQIP entity initiated in EAP for us to be able to provide these codes. If you are interested in receiving them, please contact CRISP. I do want to note that these are provided for illustrative purposes only. You won't be able to directly recreate EQIP episodes due to the sophistication of their grouper engine. However, we do want to provide them for some context as to what's in these episodes and what do these certain things mean. So once you initiate your EQIP entity, we're happy to share those with you.
And just one thing, obviously, Maddie, if you sign up in there, that doesn't mean you have to move forward if you don't want to do it, or your physicians don't want to do it. So that's not, it doesn't lock you in. And in fact, if I recall from our earlier meetings, you're really not locked in until you sign the agreement in the late fall or early winter, correct?
Yes, correct. And then anytime from September through December, there's a button in that EQIP entity portal that says remove enrollment. And you can elect to not opt into the program. So it's not locked until the performance year actually starts. So just to run through the timeline one more time, we have opened our EQIP entity portal for enrollment. Our technical and policy user guides are available. Your baseline experiences are available as well within CRISP. This is open through September for you to add individual NPIs to your care partner list and update people so that way they can pass vetting with CMS. From there, we will submit everyone to CMS for vetting. Once we submit everyone to CMS for vetting, we will have about a month of wait time for people to look at their episode elections, figure out which interventions they would like, and then we'll move forward with contracting once we get the vetting status of everyone back. So we're hoping to have contracting done through October and November for finalization sometime in early December. And so once you all have some time with the system, you'll be able to start contracting with your physicians. Though to Jean's point, you are not final participants until the performance year actually starts and you have not elected to opt out. So performance year starts January 1st of 2022. This participation opportunity will be annual. And once we start the program on January 1st of 2022, we'll do some preliminary target prices in each episode. Starting in March, we'll provide monthly performance analytics back to you all, so that way you can kind of compare your real-time performance to your baseline experience. And then we'll open the program back up July 1st of 2022 for performance year 2 enrollment, with incentive payments on performance year 1 coming July 1st of 2023. So a busy couple of months, but we'll be walking through it step by step with this. Holding any sessions that are necessary for TA through CRISP. But please reach out if you have any specific questions to your organization or questions on this timeline. Okay, so today we are going to focus on EQIP's quality methodology. If you recall, and I won't run through all of this, the incentive payment calculation has a number of different steps that help us to determine the final payout available to your EQIP entities. The third of this step is that clinical quality score adjustment. So we want to kind of dig in here today and talk about the implications of this, how we actually calculate it, and then how this policy will move going forward.
So Maddie, can you go back to that slide? So the 5% that's going to be held back, is that going to be held back out of the, so will the 33rd percentile, will they get 45% of their savings, or it'll be 5% of their 100% bucket, so they're only getting a 2.5% hit?
Great question. So it's after the shared savings cut is made. So it will be due to your, so if you were in the 33rd percentile, it would be reduced to 45% for an earn back to 50%. Does that help? So it is after we take the shared savings cut. Okay.
But the 5% is on, so it's really 10%. You know,
no, the 5% is only on the cut to you all. So it's not on the aggregate.
Okay, so like I said, if I'm in that 50th, if I'm in that 33rd percentile and my 50% is $100,000, you guys are only going to keep, you're going to keep 5% of that.
Yes, exactly.
Okay. So it really works out. Okay. Okay. Yes, that's great. Thank you.
Great. So as Dr. Grasso mentioned here, this is comes after we take the shared savings cut. And so it will only be as a proportion of your shared savings cut. So as a refresher, there will be an EQIP entity specific quality adjustment to the final incentive payment after your shared savings cut as a 5% earned back. So we will essentially pull back 5% and assess your quality to see what proportion of that 5% is earned back. For each attributed episode, we will assess whether 3 measures were performed by any physician within the 364 days preceding the end of the episode. So if your episode ends 90 days after the trigger date, we will look back 364 days to see if these activities or measures were performed on that beneficiary by any physician. Again, when we were selecting these measures, we wanted to make sure we could measure at the physician level. We could measure off of Part B claims, so you all didn't have to submit anything to us. That we were aligning with QPP standards and finding high priority measures that are included in that program. And that we were also aligning with Care First where possible, and then also with our statewide integrated health improvement strategy.
So Maddie, another question, sorry. When you say your look back is 364 days, and one of these things or one or more of these things was done by any physician in the past 364 days, you mean any physician in the EQIP entity or any physician at all? So if their primary care provider documented an advanced care plan and BMI, does that count?
Yes, so any physician at all in the state.
Okay, perfect.
Maddie, this is Cindy. I have a question about that. So that does presuppose that all those physicians are submitting these quality codes on their bills, and they're not submitting their quality data as ECQMs in the MIP system.
Yes, so this will be for those billable services on their claims. We won't be getting this through ECQMs.
Okay.
I think this is something we might want to mark for discussion, maybe in a September, October meeting, just because I do think this is something that a lot of the practices are going to need help coordinating, because a cardiologist or an orthopod probably isn't used to having a discussion about advanced care planning.
Well, and it's really not a good proxy for quality for what we do anyway. I mean, none of this has anything to do with the quality of orthopedic surgery. So I would rather look at
Right.
patient reported outcomes and things like that.
Yeah, and we'll talk about quality development in future years. For this first performance year, we needed to have something that met CMS standards, but then also were activities that we thought were just generally good when a procedure is occurring, you know, making sure if you're putting someone under anesthesia, making sure you have their medications documented, making sure there's an advanced care plan. The BMI screening becomes pretty important when you're looking at some other disease patterns. So we felt, you know, as a baseline, these would be good to include, though it's definitely not where we're going to stop with this adjustment. And it is a relatively small proportion of your final incentive payment. So I'll talk through how we also scale it, but we do want to grow from here. I'll also note, as we're talking this through, if you look at the table below, we provided the CPT codes for claims measurement. So on the left-hand side, you'll see everything that's billable. So it's actually billable service available to all of these specialties. On the right-hand side, though, we are going to also be measuring tracking codes. So if you know the service is being provided by another provider, then you can add on to your additional claims just that tracking code that, yes, there's an advanced care plan documented within CRISP, or yes, there's current medications are documented within CRISP to the point where you feel appropriate there. So those tracking codes, I think, will also help physicians kind of meet the metrics that they would aim for in these three baseline measures.
And MedChi is having a discussion with CRISP about, are there ways that we can help hit these quality measures for physicians in an intelligent way that's kind of standard for the measures. Maybe there's some things we can do to put in place to help some of the practices with this, because I don't think these are so burdensome they can't be done. I've seen a lot worse quality measures in other programs. So, and I do think we can figure out a way to standardize them so we can help people be successful.
Yep. I'll also say we've done analytics on our end to see if these are feasible. So there are gastroenterologists, cardiologists, and orthopedics doing these on these episode types. So these measures we can find on the episode types. They're not plentiful. We definitely would like to increase it, but it's not unheard of for an orthopedic surgeon to be performing some of these. So we felt comfortable moving forward there as well.
I mean, we're actually doing these right now, as well as a few other ones just for the MIPS. So these are three of our MIPS qualifiers. So
any other thought was for practices that maybe weren't as advanced, the medication reconciliation is helpful towards the opioid measure in the public health, the Maryland public health plan, the quality measures. And obviously the BMI is helpful towards the diabetes measures for the plan. So these align with and help other things that the state is doing. And that was the other logic of why they were picked.
Since some of the particularly more urban specialists will have a lot of different primary care practices that they'll be trying to coordinate these measures with,
Will there be an opportunity, since these are claim-based, for CRISP to have some reporting available so that people can see whether there are gaps in care for these measures as we progress?
Absolutely. Reporting on this quality measurement is one of the first things that we want to bring up into our performance dashboard. So that way you guys can see the by provider kind of breakdown of how your performance looks in the baseline, and then also, track it over time. So that way people can make sure that they're meeting them throughout the year. So that is an analytic that we're preparing now to bring out to you guys.
And one of the things we're talking with CRISP about is, once we have an idea of where the gaps are there ways we can create standardized programs that are efficient and have economies of scale so we can implement them and maybe fill those gaps?
We want to promote coordination, but then also these good activities from continuing in the state.
The other thing we're doing and this is more directed towards the smaller practices that we're hoping to participate, is I have the MedChi billing folks putting together billing and coding guidelines for the quality measures too, which will hopefully encourage people to do it, because one of the things about all three of these quality measures is you can separately bill for them. So that was another benefit of using them as part of the program. You're getting paid for the work that you're doing.
Okay, we'll go into how we're actually going to score or measure off of this. What we're going to do is we are going to set statewide performance thresholds and scale the scoring based off of the relative performance in the baseline. So we will essentially assign points based off of your EQIP entity's quality performance during the performance year relative to these baseline thresholds. For first year participants, your performance thresholds will be determined based off of your 2019 baseline experience and the 2019 statewide experience. We will also hold this constant for 3 years, similar to that target price methodology. For entities that enter in later years, say performance year 2, your baseline utilized will be the baseline prior to your entrance. So for 2023 participants, you will get a 2022 baseline and thereafter, similar to the target pricing methodology. So for each quality measure, the distribution of performance rates for all performance rates in the baseline for all baseline care partners will be used to determine the threshold specific to each quality measure. We'll essentially assign 2 cut points, the 80th percentile value being the highest, where you earn the full maximum of points, or 10 points, and then that 20th percentile value being the floor, where you earn 0 points. So once we look at the statewide experience, we'll kind of create those 80th and 20th percentiles, and we will scale within those to get the actual score thresholds. So once we get that baseline threshold scoring set, or that kind of that set there, we will move into performance assessment. So the portion of your 5% earned back will be based off of kind of a 3-part calculation. The first is that we'll score each quality measure. The score will essentially be the sum of your measure flags divided by the total count of your episodes times 100. So for each of the 3 measures, you'll get 1 score. And then we'll aggregate those scores. So we'll look at that performance scaling, but that baseline threshold scaling, and we will compare those scores back to it. So say you're in the 55th percentile, you will get X number of points out of 10. If you're in the 80th percentile, you'll get the full 10 points. If you're in the 20th percentile, you'll get 0 points. Then we'll aggregate across the 3 measures. So we'll essentially add those up. Say your total score was 25 out of 30. That third step is we'll convert it to a percentile. So we'll essentially divide 25 by 30 to get your percentile rank ranging from 0 to 100. And that will correspond to the percentage of the 5% that you earn back. So you can earn either 0% of the 5% back, or you could earn 100% of the 5% or half of it back. And that directly corresponds to the proportion of the money that you will get. So fairly simple, we'll just compare it back to thresholds. In our user guide, actually, we have the actual scores by percentile ranking published. So I would encourage people to go look at that chart. It's just a little detailed here. But it's a pretty simple scaling for you to be able to see, oh, I'm performing at this rate, at this percentile, I can expect this amount back. So in addition to this quality assessment, Since EQIP will be an AAPM, this will act as your exclusion from MIPS and then also give you that 5% Part B bonus. We really wanted to ensure that we had a strict quality standard on the program, and then also ensure that a relatively small quality adjustment would not be an incentive to not pay attention to quality. We think quality is very important in the episode quality improvement program. So we want to keep a stringent standard on these measures moving forward. For entities who achieve minimal quality performance, we'll have two kind of corrective actions set into place. The first is that if you're below that 20th percentile benchmark in one performance year, we will put you on quote unquote probation. Again, this is based off of statewide experience, not just EQIP participants. So we really expect our participants to be performing above that 20th percentile fairly easily because there's attention and incentive to do so. If you're below that 20th percentile benchmark in more than 2 years, so you've been on probation for 2 performance years, we will actually automatically remove you from the EQIP program. This is again because you are getting that QPP status through the AAPM side. We want to ensure that quality is very strong, but then also that you can't ignore the quality performance standards that are being set in the program. They are important to perform on, and we will be keeping kind of a strict eye on those. So as I mentioned, we don't expect for this to be a high hurdle for any EQIP participants since it is based off of statewide experience, but we do want there to be some sort of repercussions for non-attention to quality within the program. Are there questions here? Great. So as I mentioned, we do have plans for future performance year quality development. We definitely want this program to have a strong eye towards quality and then also progress as, the national programs are progressing, but then also statewide as we're kind of excelling there. So the first area that we want to explore with this subgroup is the Prometheus episode grouper actually tags potentially avoidable complications on an episode specific basis. It's gone through a number of clinical panels and testing to ensure that they're relevant. So we actually want to kind of explore this opportunity and see if there's an availability for us to apply that as a quality measurement within EQIP. So for example, within the colonoscopy episodes, Prometheus will automatically flag codes and then costs associated with perforation or abdominal abscesses, things that probably shouldn't happen with a colonoscopy. They do this for every episode on a very specific basis. So we think this is a great opportunity for us to leverage that Prometheus episode engine. We also want to ensure that we are always aligning with SIHIS, our statewide health integrated health improvement strategy. Among that, one of our other population health goals is opioid use overdose deaths. So we are looking at maybe an appropriate opioid prescription measure and figuring out how we would be able to measure that off of claims. We'll also align with MDPCP and other physician programs nationally where possible. So I know there actually was just a big MIPS rule that was released yesterday, and we'll take a look at that and make sure that EQIP is aligning there where appropriate. We also, at the HSCRC and across the state, are looking at improving health equity in all policies. So wherever we can keep an eye towards health equity and addressing health disparities, we are committed to doing so in each of these programs. So as measures come online more, as we implement them more in other HSCRC programs, we are going to be taking a look at how that could apply to EQIP. Additionally, since EQIP is going to be incentivizing shifts from the inpatient setting to outpatient and ASC settings, we want to look at maybe some measures that are more specific to non-hospital settings. And we want to ensure that we are disincentivizing facilities with very poor quality performance and more incentivizing these facilities that have a stronger eye towards quality. Additionally, we want to make sure that anything we do moving forward is physician focused and gets more episode specific to Dr. Grasso's earlier point. We want to be able to measure the actual quality off of some of these conditions of care more closely in future years. And then lastly, we are very interested in patient reported outcomes measures since that's actually how patients experience the healthcare that you are giving within these episodes. And so as we in the state and nationally bring those into more programs, that's something that we'll be watching closely for future year development. Again, this list is not exhaustive. So if there are any ideas or thoughts that you all have on quality with an EQIP, please feel free to chime in now or send them over our way. But we are excited to kind of get to develop this further with you all after we get the first program year launched. Comments, questions, concerns, additions? Great. So that's kind of closing out our quality methodology. As I mentioned, the user guide online details this in exhaust. So please go and read that if you have more questions there, but I'm also happy to walk through the methodology with anyone who might be interested. Okay, so now we are going to get into some statewide opportunity analysis, since all of you all are hopefully logging into EQIP and hopefully seeing your baseline episode costs and getting a sense of what it means for you in the program. But we also wanted to provide just a statewide look at what this means, and then conversations. So we wanted to tee up some of the conversations that we want to have later this fall around performance reporting through CRISP. So again, your baseline episode experience that's available in CRISP right now through EQIP is used to establish a couple of things. It helps you establish your EQIP entity, make sure that you're getting that eligibility and those thresholds set. It also helps to give you a sense of cost per episode, though again, this is not your target price. It's also what we will base the quality scoring thresholds off of, and it is how we will determine your tiered shared savings ranking. What this isn't is, and I've said it before, is that these are not the target prices for your performance in the program. We will provide the target prices at the beginning of the performance year, so 1/1/2022. These target prices will be your baseline costs, so very similar to what you're seeing now, though they will be inflated forward 3 years to make them more comparable to real-time costs. So there's a PPS update that comes out in October that we are waiting on, that we want to inflate the costs with, so that way you all have some relevant episode costs. We also will continue to inflate this baseline forward throughout the performance year as costs grow nationally. So the target prices will not be final until the end of 2022. Though I will say whatever you are seeing in your performance dashboard will be comparable to what you are to your target price baseline. So it's just a real-time update that we are going to be providing throughout the year. Some other reminders for the episodes that you all are seeing back through EQIP that we want to note here. The first is that EQIP is only for Maryland Medicare fee-for-service beneficiaries who are enrolled in Parts A and B. If they are on Medicare Advantage or have ESRD benefits through Medicare, they will not be included in these episodes. So if you have a significant Medicare Advantage population, a lot of those episodes won't be reflected in what you're seeing in your baseline. Additionally, episodes trigger on a specific CPT code set from professional claims, accompanied by an ICD-10 code indicating a relevant diagnosis. It's that CPT code, ICD-10 code combination that specifically triggers an episode that we want to make sure to note here, so that way people are not confused. And again, if you are in the EQIP as an EQIP entity, I can provide you back what those actual CPT codes are. Additionally, episodes are attributed to the rendering provider on the professional claims. So episodes will go to the provider that is put into that rendering position on each claim, on the header claims. Only episodes that complete prior to December 31st of the baseline or performance period will be included in counts. So that means if an episode ends 1/1/2022, so if it ends in our performance year, it will be included. So if it started 90 days back, there actually will be some 2021 experience impacting your 2022 performance. So I think that's important to note now for anyone who is getting involved in maybe some of our longer episodes, that being the lumbar laminectomy, I think, and spine fusion are both 180 days. Some of those episodes could be initiating now. Granted, there'll be some of your earlier January end episodes, but they could be initiating now for performance. Additionally, the lowest and highest cost 5% of episodes are filtered from data in addition to zero cost episodes. So if we see claims with zero, we are filtering those out. Inpatient colonoscopy and endoscopy episodes are excluded. So those two episode categories are for the outpatient services only. The reason there is that we do think that there's a very wide gap in the reasons that inpatient colon versus the typical outpatient procedures that we see. For episodes that are less than 90 days as well, if there's a gap in a beneficiary's coverage for more than 1 day, those episodes will get filtered out as well.
Hey, Maddie, question on the point about the lowest and highest cost 5% being filtered. I can understand and very much agree with the highest, so you don't get outliers that blow your bundle or blow your performance. But I'm not quite sure why the lowest 5% are filtered. Zero one's filtered out, obviously. But if we're doing stuff very efficiently in a surgery center and the bottom 5% of our cases are all good cases that were done in a surgery center at lower cost, why should they be filtered? Why should we get negatively impacted by that?
Yeah, so the base answer, and some of our statisticians who worked on this can chime in, but the base answer is we are following a typical Windsorization kind of statistical approach for stability purposes in our data. So including kind of those outliers, if you kind of think about a bell curve and where costs fall, I don't think it's going to pull in a ton of the lowest cost providers or cut out a lot of the lowest cost providers, but more the erroneous kind of odd tail ends of our distribution. So
normally a Windsorization, as far as I know, when you're doing a bell curve, it's 2.5% or 1 standard deviation above the mean. So 5%, it just seems like that's going to penalize efficient guys who are doing stuff that, if they lose 5% of their cases from their data, it's going to hurt. Now I can see if they're way outside the norm, but it doesn't seem like 5%, an arbitrary 5% really does that.
Yeah, so due to small cell size as well, we had to increase from that typical 2.5%, right? Because we're measuring back down to the individual physician level. Again, we don't think it impacts the distribution in a way that will cut out a ton of your episodes. But as you're looking at your statewide ranking, you can kind of talk back to us if you think it's having a significant effect, though I really do want to highlight that it's outliers in small cell sizes.
So this is Will from the HSCRC. Just to add to that, we're not dropping the cases, we're Windsorizing them to the 5% value. So you're still benefiting from having low cost episodes. And so you're not being penalized in that way. I think in our actuarial judgment, the difference between a 1% cost and a 2% cost is not statistically meaningful. We tend to have a lot of cases at the lowest, that are zero. The difference between a zero cost and a $25 claim is not statistically meaningful. So, that was our judgment, but we're happy to get into it more with you offline.
Okay, thank you.
Great. Okay. I also forgot to mention this, but we are at the outset, before I get into numbers and kind of breakdowns, we are joined by Dr. Andre Gonzalez, who's the VP of Product Development for Prometheus at Change Healthcare. And he really is that clinical expertise that can answer the what to some of these cost numbers if you have questions as we're going through. I am not the clinical expert here, so we're very appreciative to have him on as we kind of walk through this should there be any specific questions. But I wanted to mention Dr. Gonzalez was on with us as well right now, which I neglected to do. Okay, so we presented some of these in some of the more specific sections for cardio, GI, and gastro, but we wanted to give you a sense of the overall baseline experience in the program. Looking here, the first half of this table is for cardiology procedures and the bottom half for GI. Though statewide, I do want to note that we're covering about 67,000 different episodes for about $965 million of cost. If we assume a general 3% savings rate, that's about $29 million of savings that we could generate and then share back with physicians who participate in the program. All this to caveat, that would mean that we have 100% of specialists participating statewide, which we sure hope we get close to. But we do think it's a significant opportunity as a state that we have available. So looking at these cardiology episodes, they do vary, based off of some of your more typical, more costly procedures such as CABG or valve, and then getting a little bit more standardized across AMI, angioplasty, and pacemaker episodes. However, the volumes differ, right? So some of those lower cost procedures are a little bit more plentiful, and that CABG or valve procedures are occurring a little bit more sparingly statewide. Overall, across our cardiology episodes, we're covering about $351 million. Looking at the GI episodes, again, you have your more plentiful, higher volume, but lower cost episodes, colonoscopy and upper GI endoscopy being those. But the lower volume episodes carrying a significant more amount of cost and opportunity to save on. So in total, we're looking at about $140 million across the GI suite of episodes statewide. And then I also do want to note the first two columns here after the episode categories indicate how long each of these episodes are. So the time preceding the trigger date that is counted. So for a lot of the more planned procedures, a 30-day look pre-trigger window duration. And then for some of the more complicated procedures, the post-trigger window duration is a little bit longer. So just providing that here for a little bit of clarity on what's getting pulled in. Looking at the statewide orthopedic experience, we are, again, seeing that variation between volume and cost. Looking at some items that are a little bit more common, like hip, pelvic, and fracture and knee replacements, versus, some things that are a little bit less common but higher expense, such as lumbar spine fusion. Again, that variation presents, I think, a couple of opportunities for savings, and it means that we can be getting these savings not from just one place. Looking at our orthopedics suite of episodes, we're looking at about $475 million of total cost. And we'll be sending out these slides so that way you all have these statewide numbers to sit with. So that way everyone kind of has a common resource for the first performance year. As we're looking at episode costs, we really wanted to kind of dig into again and refresh on what Prometheus is actually doing here. Again, they're taking total cost of care and dividing it back in, and more carefully dissecting it into costs that are actually relevant to the episode, so that have relevant diagnoses on the claim, that have relevant services on the claims, and then costs that are not assigned to the episodes. So costs not assigned to the episodes include things that aren't related back to that initial procedure happening. From there, Prometheus goes a little bit further and it splits into kind of two categories. One is the cost of typical care. That's provider practice patterns, your routine services, things that you've already been doing. Again, your target price is based off of your 2019 experience. So it's based off of your case mix and your historical practice patterns. We don't expect for you all to go in and evaluate how many E&M visits need to be reduced or how many PT visits can be reduced in the future, if that's what you've already been doing to ensure good quality care to your patients. Where we really see the opportunities for cost and quality improvement are in those two green boxes. Prometheus helps us to tag the costs of potentially avoidable complications, and we'll talk through more of how those are tagged in a second. But then it also helps us to tag overuse services and setting selection where appropriate. So these two areas are really where we want to provide insights back on each of the episode costs, and really where we want to help people by giving them enough information so that way you as physicians can tailor the interventions and tailor how you want to succeed in the program. So I'll pause it here and see if there are any additional questions, and Dr. Gonzalez is on so he can answer anything more specific there as well.
Maddie, you mentioned that the baseline data would be available to physicians, I guess, once they get their NPIs loaded into the system. Will there be any opportunity to have a window into geographically for the area in Maryland where you are, how you're comparing to other groups before you make a final decision?
That's a great question. So I think two parts. I think, yes, if we think that stakeholders are interested in having that sort of performance analytics, we would definitely look into building it. However, I don't think that will be available prior to your episode elections. So your actual incentive payment is not much based off of kind of your geographic comparison. It's based off of your historical case mix. So your performance won't really be tiered to that. I recognize it might be a helpful insight. where you might be able to see it though is in your tiered savings ranking, right? So you'll be able to see where you are relative to the state via that ranking, which is available in the baseline.
Thank you.
Okay, so we'll move on to some insights. So as I mentioned, Prometheus provides a number of great insights for us to utilize and kind of figure out where different savings opportunities might come from. They actually go through and tag costs that are come from complications and from potentially avoidable complications. Again, we're not going to penalize you based off of this, but it's insight for you as clinicians to take away within each of these episodes. So those larger green boxes are costs due to complications. So that's any inpatient costs, which may include costs attributed to one or more potentially avoidable complications as defined by the algorithm. However, further claims investigation is required to determine if they were potentially avoidable. So they're marked as complications or costs due to that inpatient complication care. But that darker green box is really costs that have been specifically identified in the episode definitions as potentially avoidable. And so if you look on the right-hand side, we kind of give a proportion of each of these costs. So while CABG might be the more expensive procedure for you to engage in, there's more opportunity to reduce those potentially avoidable costs, with about 8% of costs coming from there. In all of these episodes as well, I will note that the bulk of the costs are coming from complication care and potentially avoidable complication care. So again, opportunity in terms of intervention for you all to kind of think through. What the dots on this slide are indicating are coefficients of variation among episodes. So this is among statewide. We'll do it at an EQIP entity level for you all. But again, where there's more variation among episodes, more opportunity to standardize maybe across your practice and bring that variation down to a more standard cost level. So whereas CABG is maybe one of our higher cost episodes, the cost actually with the most variation within the cardiology suite are AMI and coronary angioplasty. Again, I think the benefit here is there's no one way to split the opportunity. You as clinicians can kind of dig through and see where the bulk of your opportunity might be, and then tailor your interventions and approach to performance and EQIP based off of these insights that we provide back. And I have one of these for each of the specialty areas, so we can walk through them or ask questions now on anything, but please feel free to chime in. Great. So looking at orthopedics, obviously we have those higher cost lumbar spine fusion episodes, though with less variation than some of the other episodes that we're seeing. The highest potentially avoidable costs is coming from our acute episode and hip and pelvic fracture care, though there is a significant amount of potentially avoidable costs with lumbar laminectomy, lumbar spine fusions, etc. The most variable cost, though, is one of our actually lowest cost episodes, that lumbar laminectomy. So if you look at that dot way up there, there's actually more opportunity to kind of standardize and average out the cost per episode across providers in this episode. So again, we'll send these slides out so you can kind of sit with these for a little bit longer. And then these are this is some of the direction that we'll be headed in when we put out that crisp performance reporting opportunity. And then finally, looking at gastroenterology, colorectal resection being our most expensive, but upper GI endoscopy being our most variable. So different opportunities there, different interventions, for you all to kind of tailor as physicians. When we kind of get into talking about insights for performance reporting, we do want to note that when possible, we are going to be trying to report out any data at the care partner level. So that way across your EQIP entity, you will be able to see each individual physician's performance in addition to the aggregate EQIP entity performance. We don't dictate the split of the incentive payments across your EQIP entity. We want to leave that up to you all. So whatever metric you choose to make the split on, whether it's proportional, whether it's based off of volumes or performance and quality, really however you all decide within your entity to create that split among care partners. We also will report insights at the clinical episodes category, which might include PHI. So while everyone's getting credentialed into EAP, if you already have PHI access in CRISP, you will have access automatically to that performance dashboard. However, that is an extra step in credentialing in CRISP to get access to that patient level data. So that will be one extra step that we can work through in the next couple of months to get you all on board with the PHI access for when the performance dashboards are available. However, I will note for a final time, the reconciliation and incentive payments are going to be made across all of your clinical episode categories in which an EQIP entity participates. So it's not made at the individual physician level, it's made at the EQIP entity level, and it's across all of your episodes. So if you participate in hip fracture and hip replacement, the reconciliation will be done together. Additionally, we want your insights when we're developing our performance analytics a bit further. These dashboards will be rolling out starting March of 2022 for the first year participants. Some performance insights that we are looking towards are that potentially avoidable complication costs and rates data that I just showed you on a clinical episode category level, perhaps on a physician level. Place of service costs and rates among each of those place of service. That quality baseline and performance will be available in our performance insights. And we will also likely develop raw data sets for EQIP entities who are interested in performing their own analytics on their own episodes and performance. So we will hopefully be able to provide that downloadable kind of raw data file for those who want to do their own sophisticated analytics. In September, we do want to discuss further where we see performance opportunities within our own statewide data, and then also how reporting will look to you all. We don't want to build reporting that you all don't think is important or helpful. We definitely want to build out reporting that will be most useful to you managing your performance, and then also management of EQIP participation. So if you have insights on what you would like to see in these reports, please provide us feedback. CRISP has actually developed a user forum, kind of like a message board, available via this link at the bottom. If you click here when we send out the slides, or take a quick screenshot and just go to the URL, you can actually post what you're thinking about or what you would like to see in the performance analytics. From now until that September meeting, we'll be taking a look at that to make sure that we kind of have a pulse on where participants are potentially thinking. And then we'll have that larger discussion for you all during that meeting. So we're really kind of looking forward towards performance now that we've gotten through all of that initial enrollment and signing up kind of phases of setting up EQIP. And so we're looking forward to being able to discuss that with you guys. There are questions, comments here?
So Maddie, just to clarify, the graphs you just showed us, that is statewide data, opportunity information on statewide data from 2019 claims.
Yes.
Or from 2019 claims? Okay. And it's an example of what we'll be able to see on our performance dashboards, but that won't be until March of 2022.
Yes. So on performance costs. So we'll provide any kind of statewide views of these episodes, so that way you can get a sense within each of the episodes. The quality reports, I'll also say we probably want to push out a little bit earlier because it'll have your baseline performance. But in 2022 is when we'll actually be able to get some performance insights out due to claims run out, and making sure that we have enough data to actually start pushing out to everyone monthly.
Okay, thanks.
Okay, so I wanted to leave, and I've seen some chat questions, so apologies for kind of moving over to them. Or not moving over to them, but are there any final discussion questions, or I can quickly turn it over to Jean if you want to say a couple of words?
No, I don't have much to say other than I did, when Adam asked the question, I did kind of volunteer care first to respond. So hopefully they saw that, because I do think that was a good point in the chat when he suggested the idea that we try to integrate the care first performance with the dashboard, if that's possible. So obviously that's it might be a care first issue. She's probably going to have to go back and talk to them, but I thought that made some sense. But anyway, I didn't have any other additional comments or anything. other than to say thanks for all your work. And please, I just want to reiterate, talk to your colleagues. And I see we have quite a few physicians on the call this morning. Let them know, because we do keep running into docs, particularly the smaller docs, the private practice docs, who are not aware of the opportunity. So please make sure they're aware of it so they can at least make a knowing decision. Because if they don't sign up by September 1, if they don't get registered and sign up, they can't do it again until the following summer to sign up for the following year. So it kind of puts them behind everybody else if they really want to do it. And also by getting in this year, there's no guarantee that you're going to get a full 3 years on the payment. Isn't that correct, Maddie? If you wait a year?
We are closely monitoring the way that the AAPM status will shift in QPP over future years, but this is the final year to get in for that 5% bonus. So the future years, such as the exclusion, future year rate increases above what normal fee schedule for physicians is. So there's still benefit to being in an AAPM beyond this year, but this is the last year for that 5% bonus.
Right, and then also this year you lock in at the baseline for the year for your payments. And I guess my point was there's also no guarantee that that baseline year will be the same for next year. We don't know what CMMI might do or what might not do. So there's just a lot of reasons to consider doing it now. It's also possible some of the other rules could change in the future, because they do in these programs. So just encourage people to look at the opportunity and make a knowing decision this year. So unless Tequila or Maddie, you have anything else, I guess we can get done really early today.
Yeah.
No, I think that's it, Jean, with the exception of, again, a heartfelt thank you to you and to MedChi for all of the support and partnership that you've had with us on this program. So we just appreciate it tremendously. And thank you for your willingness to continue to work with us on this.
All right, guys. Well, everybody have a great weekend. And remember, there's no EQIP meeting in August. We are not going to be meeting on August 20th. Okay?
Great. Thank you all.
Thanks.
Thank
Thanks.
you.